If it's okay with the chair, I think we should begin. What do you think, Raya?
I think that's
Shall I,
fine.
I'll share the agenda. Does that
That
sound
would be wonderful.
1 second, please? Hopefully everybody can see the agenda.
Is everybody on? Because I'm getting emails about people having only authority to view but not to contribute. So I don't know if is it all fixed?
Yeah, I believe for some reason this meeting was set up so that people were automatically listed as viewers rather than contributors.
Okay.
But I believe we fixed that issue.
That should be that should be resolved.
All right, wonderful. Yes, I'm seeing the colleagues that send me emails. That's wonderful. All right, Mark, I think we're ready.
Let's do this then.
Yes.
So welcome to our final meeting. I really very much appreciate everybody making it. Any comments that you have, Raya, to the group?
I wanted to say I'm just so sorry. Last time we had changed the timing of the meeting, so we didn't have the full complement of the team. And for those who attended, and just so grateful for all the hard work that went into the tasks that we're responsible for, and look forward to a great final meeting today. It's not really final in terms of the product, but it's the last formal meeting that's scheduled for us. So it's so grateful for all the work. It's really, I went through all the documents, and it's just really impressive amount of work and intelligence and thinking. It's wonderful.
Yeah, I completely agree. And I want to thank the group we started with very little, right? And we really have really a ton to work with now, and it's really looking very, very good. So I wanted to thank everybody for participating and adding your input into all of this. And as Raya had said, this is the end or the final meeting for our formal groups, but I want to make sure that the group is aware that this is just the beginning, really, of our LRM project. So while this formal group may be kind of concluding, you're certainly going to be able to continue to participate in this in a variety of different ways, in terms of being able to participate online and in town halls and other ways that we plan on sharing this information. So thank you. I did want to say, and I'll jump right into the next item if that's okay with you, Ryan.
Of course, yes.
One of the things, we changed the format of this meeting a bit to try to address some of the needs and concerns of some of the the work group members. So what we're doing, there's a bit of a change in format. So we're going to do a 20-minute kind of a speed round for the breakout group, and to really focus on getting our objectives and strategies nailed down. And then we're going to come back to the roundtable larger group to discuss and further hone down and answer some of the questions that may still be challenging to the smaller work group or subgroup. So that's the game plan for today's meeting, and that's kind of what we're trying to accomplish. We did provide the group the links and all the information we had to kind of prepare for this meeting. So I want to thank all of the members. We got some great feedback on a lot of the work that we were doing, so we should be able to hit the ground running at today's meeting, and really get the goal today is to have a finalized objective and finalized strategies. That's our mission for today. before we break out into the breakout groups, the first one of the first objectives of that breakout group is to edit and finalize that one objective we are allowed to have, and then edit and finalize those maximum of the 8 strategies. Now, some groups, some of our subgroups have twice as many strategies than 8. So it might take a little bit to narrow it down, but we've done our best to summarize a lot of the conversations that were had and to try to provide some structure to some of the, like we were saying, the strategies. If there's time in the breakout group, and you find that the strategies are fairly well nailed down, and that the objective is fairly well nailed down, there are short, mid, and long-term kind of time frames we wanted to try to put to those strategies. And at the very bottom of those pages that we provided are 8 questions, supporting documents, supporting information that will help us kind of move those strategies forward. So I don't know if that we're going to have time to get to those 8 strategies on top of everything else, but maybe in the main group we can come back and fill in the blanks with what we have left of our subgroups. I don't want to talk too much. I tend to talk too much, and I realize that. But I wanted to give a feedback for a little bit of an idea of what we're planning on trying to do. So does everybody feel pretty comfortable with what we're going to kind of dive in and do? That 60-minute session that we're going to come back and discuss, we're going to come back and the leader of each of the subgroups is going to present on the objective and the strategies that were decided. Because we have 4 subgroups, we'll take 15 minutes each to kind of go over what they've accomplished and where the challenges they still see lie. And we will discuss and provide assistance as necessary to support the groups. Hopefully it sounds like a plan.
Just want to check in before we set up those breakout rooms. Is everyone able to access the objectives and strategies template that we shared in the email before this meeting?
Yes.
Okay, perfect.
Yes.
I don't think I could make changes to it. I couldn't access it in that way, but I can view it.
Okay. Yeah, let me double check on that.
Andrew, it's the same. You know, I had just to copy and paste into a Word document in order to work on it.
Oh, that's odd. You should have been, you know, the goal of that was to be able to edit it online.
Yeah.
So we will make edits along the way. I'm going to ask each of our staff to open that up and work in that document as we move forward. For the transportation subgroup, I did add the conversation that was recently had with the Department of Transportation in that document. So you'll see that that first objective is the kind of that conversation, and below that conversation and those objectives and strategies were the previous ones. So both are there. Yes, ma'am, Liz?
Just quick clarification on that. You know, based on a conversation with transportation and reading of some of the materials, I went through and put some recommendations out to the group for their review. So that language doesn't come directly from the Department of Transportation. Just want to make sure that's clear.
Yes, thank you for that. I didn't want to misrepresent that. All right. Unless there's any other questions, are you okay, Andrew, you think?
Yeah, sorry. There's going to be a few folks that are left out of the breakout rooms initially, but we can go ahead and get that sorted. So I'm opening those rooms now, and folks should be able to join. Sorry, I apologize. Who has the Washington Area Villages Exchange?
Mary Jo Deering.
Mary Jo Deering.
And I should be in the social connections.
Perfect. Thank you for that. And the other person that I'm seeing here is Nancy Gompers.
Hi, I'm filling in for Leanne Eagle.
Okay, okay. Perfect. So I will put you in person-centered care.
Thank you.
Of course.
And JJ, if you're still there or not, I'm not sure, but if you can put a 20-minute time limit on the subgroups, that would be helpful.
Yeah, I'm here. Give me a second.
Thank you,
Okay.
sir.
All right, I think I got that. D. Perfect. Okay. Casey, are you able to get in the breakout room? Perfect. Okay. So it looks like we've got someone in brain and physical health. That's Mark. JJ. Oh, hi, Janine.
Hi, I was sent to person-centered care, but I am social engagement.
Oh, sorry about that.
Okay.
I share. Ooh, let me make sure that I also record this. Let me see here. If I can remember how to do that, and I should in a second here. JJ, am I able to record in this subgroup? I think I am. One second. Maybe I can't. Oh, recording unavailable. Never mind. I don't think I can. I can't record in a breakout room. Never mind. Anyway, I still can share. So that's what's going to happen. 1 second, please. So hopefully you can see this. Everybody can see that, hopefully? I'm sorry, I have a hard time. There we go. So the objective today is to really nail down this objective and get an idea and see if it speaks to everybody's concerns. I know that it was a heck of a lot to try to encompass because there were so many different areas and desires to try to get squeezed in here. But I think we have it making some pretty good sense. So what I had originally, and I'm not going to read the exact thing down here, but I had this original information put down. Kim had a very good comment. I hope that you had an opportunity to read this when we sent it out. Kim suggested that we really change. Well, you looked at the received portion and you had a little bit of a concern with it, right? And you wanted to make sure there was some cultural appropriateness put in there as well. That sound right?
Yeah, I also with the and what I recommended, if you could add trauma informed after we'll have access to comprehensive, trauma informed, culturally appropriate. Obviously, there's a lot of stuff we're trying to stuff in there, but I was a little bit concerned about mostly. Can we possibly expect to measure that people are receiving care or that we are promoting access so that they can seek it? That's kind of.
And I very much agree with that. That was a really good catch because we're not going to, I don't think, in my opinion, unless people think differently.
To build on that, I think it needs some measurable element to it, because right now it just says older adults will have access. So specifying a certain percentage, or older adults with Medicare, like it needs some measurable element, I believe, in order to align with SMART goals.
Correct. Now here's the conversation we had and I am not disagreeing with you at all, but I think the challenge is that we are not sure of the data sources because, frankly, the time frame is so quick on this. If somebody's familiar with data sources or with what might be a good baseline, because one of the conversations we had was we're not sure about what a baseline would be, so how are we going to gauge improvement if we're not sure where the baseline lies? So we've kind of held off, and the larger Longevity Maryland group said it was okay for us to kind of, if it's not possible, it's okay to kind of just have a general statement here objective. But if you are familiar, you're absolutely right though. To have a SMARTY objective, we should have a real hard measure of where we're going to be looking at these things.
I'm glad.
Healthcare.
Well, maybe it's, I wouldn't put it under research myself. The research on communicating, it might go under the cultivate culture change because that is basically communication based as you're talking about, changing language and attitudes and outreach. So it could go under 5.
Certainly hearing from you, Marlene, that it would be good to identify the resources necessary for communications in the supporting information.
Right, because 3 is pretty small right now. I think it's just 1 line. So maybe some subdivisions about communication strategies to build awareness.
But again, you're only building the awareness of the healthcare providers. They're the only audience for number 3, as I understand it. So if you're trying to promote effective communication, which I think is a very good point, we'd have to find, well, maybe we can drop down below and find a home for it. I just want to make one, point on number 8. I actually put the word incentivize in there. I think it was, promote, or I think it was just encourage. And frankly, I think we're at the point where we need some stronger language sometimes that says, don't just think about it, don't just identify it and promote it and say it's a wonderful thing. But incentivize, in my mind, at least implies you're maybe going to put, positive resources behind it. So that was my suggestion there.
If we're doing feedback on number 8, I have some as well, but do we want to digest that and incorporate what was just shared now before I jump in? Or should I just share? I don't want to take over here.
Are you looking at the high level, or are your comments based on the lower level details?
Well, it's both. I mean, I have a very concrete way to adjust this statement, but I want to share why,
Okay.
So for example, in number 8, I want to ensure that engaging a paid workforce isn't lost in this because, for example, professional artists and therapists, et cetera, they would be paid for work like this.
Mm-hmm.
So I don't want to lose that in here, so that we have economic and professional inclusivity. And so I thought, incentivize volunteerism and professional support, especially and then the rest.
Mm-hmm.
I think if people could really make some specific concrete adjustments, like, what you want to see this say, it'll help. We don't have that much time. It'll help us move through this quickly. So that was kind of how I was thinking for this one. And I did the same thing for number 7. I mean, number 7, I have some feedback too.
Go for it.
Okay. So promote intergenerational programming and arts engagement opportunities. And then there's a specific example that is somewhat ageist to automatically point to memory conditions. And then to recognize that we're all aging doesn't really, it's not inspiring. And so I think we want to, and I'm thinking about like the reframing aging communications package that we were all, I think it was in this group and maybe another work group that I'm in with the county, but this is something that the Gerontological Society of America and other national leading organizations are kind of sharing about practices. And of course, this is ageism too. So like, how about promote intergenerational programming and arts engagement opportunities to culturally advance and embrace that we're all aging. So this is all of us, not they and them, that we're all aging and that our communities are better when they include the full scope of our energy, ages, contributions, and imaginings. So like a positive paradigm and a vision rather than it's all about memory.
Remind me the end. I think it's really beautiful what you're saying.
Where are we? Let's see. Where they include the full scope of our energy, ages, contributions, and imaginings. Because again, like the imaginings piece is like, we don't always have to remember to feel a sense of purpose. We can imagine to feel belonging.
I think that's a great use of your reframing aging hat. Congratulations.
Thank you. We did an equity jam in my organization the other day, and I was sharing, that was one of the focal points, was that communications package. It's a great framework. If folks don't have that, I'd be glad to share it with you.
Wonderful. Other thoughts? Did other people have sort of specific?
I think the way that we anticipate that this will go is that each group will kind of present on the objective that they've identified and then talk about the strategies. And if anyone has questions about the supporting information questions, then those might come up during that meeting as well. But I think that this is the chance for people to comment on some of the other subgroups that they might not have been able to participate in, but we're still interested in providing their feedback on. So I think the majority of this I'm anticipating is going to be focusing on the objectives and strategies, but there might still be some discussion for that supporting information section. Were there any other questions there that kind of jump out at you guys? The first one that jumps to my mind is MDOT's complete street strategies for number 6. What existing programs or initiatives support these strategies?
Okay.
I think number 7, the input and priorities of older Marylanders. I think that one's a little challenging, and it would be great if there were some focus on that, getting feedback and input. But I don't know that we can necessarily say we have done that here.
Yeah, I think just that I'm kind of capturing that feedback. Do we want to put that we want to make sure that there's a method for collecting input as part of this planning process?
Yeah, I think so. And then that can kind of go to number 5 as far as using it to make adjustments or plans for future. Whether that's surveying, I think I read in the document from Department of Transportation that they did do a bunch of surveying, and but it wasn't clear exactly who was surveyed. But then I also think all their data, those maps that they have, to keep those up as they go along, so they can see where populations are living and need.
Yeah.
Essentially, they started with how do we study active, successful people, and they spent 10 years. The MacArthur Foundation funded this massive study, and essentially, so that's really the foundation work on how do we start with healthiness, not with disability, and then the 4M model essentially started with how can we empower, how do we be more responsive, and how do we get better outcomes by focusing on the 4Ms, starting with what matters.
That's right. That's right. That's right. That's right. Okay. Melissa, are you okay with that? I know you focus on mobility as well and function.
Yes. And in the objective, I was able to go in here and change things. I added the by 2035 because there wasn't any real criteria. But the other thing that I wanted to let you know that I made changes within the recommended strategies, almost all of them had the word patient. So I changed all of them to older adult or older individual.
That's right. That's right.
Yeah, but other than that, I agree. I think we need to focus on the community-based, home and community-based services versus institution, and just look at this as a healthy aging in place. And really hone in on, like Peggy said, how we're going to measure the short term, medium term, and long term. It's right now, I think it's written very generally.
So
we can put dates in there, we can put years in there, but we need to say how many people maybe in the state are going to, we want to at least try by 1 to 3 years from now, get them to be doing this sort of thing for every one of those strategies.
I mean, definitely the question about resources is incredibly important. I mean, when I think about informed decision making, I mean, that's really the empowerment piece of it, that, you have people that are informed to make decisions. And so if we are to enable older adults to make informed choices about their treatment or and make sure that they have all the necessary support, then I'm thinking that the short term ought to be develop educational materials that outline the patient's rights and options and introduce, I don't know, in some places they use care navigators to guide older adults. So could that be a short-term strategy, like 1 to 3 years?
Yeah, like these are, so this is almost like developing the tactics, right, to go with our strategies. So, I agree with you. I know the Cancer Collaborative uses patient navigators, which seems to be a really effective program. And I don't think that it's that expensive to do, right? So they get volunteers from the community that help with these sort of things. And I also think it would help because we could designate what areas are really those areas that are underserved. So, that's another important component, right, of what we're trying to do.
Agreed.
So there's navigators in multiple areas. So dementia has a navigator program.
Oh, okay.
The
Mental illness too. Yeah.
Oh, I didn't.
the so-called MAP program, which the MAP program
Yeah, we need a little bit more time, I think.
Are we done? I thought it was an
No,
hour.
Yeah, that was, we shortchanged you on time on that one, I think. So,
You said 20 minutes, Mark. So
was that 20 minutes? Really?
Yeah.
Oh, man, we were making such great progress. It's frustrating. All right. We'll get back. Let's go to the main group then. And let's just bat it around in the main group.
No, wait a minute. I got mixed up. I thought that was the 60 minutes where we can talk about the strategies and write things down, no?
Yeah, well, I think the next step is to go into the main group and then just discuss with the group what our thoughts are and continue working on each of the strategies and objectives. Does that sound like a plan?
It sounds like a plan.
Okay.
I wonder if while we're doing that, we can identify some common themes that would sort of decrease the numbers, because we're talking about like 8 times 4, which is a lot. Because I think that some of the themes that came up in our social connections group are going to be universal, and then we would want to apply them to all 4 subgroups. For instance, communications, like making sure communications are blah, 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 but in all 4. You know what I'm saying?
Yeah, and that's, I think, one of the thoughts of why we're going to I think
so.
one of the
Maybe as
reasons
we're talking through them, we can identify like which ones would be
yes.
to all 4.
I think that's part of the thinking behind getting together as a larger group, as well as we're going to internally, as MDOA, go through a lot of the overlap and come back with some more goals and strategies that don't overlap. So we're going to be working on that internally as well. But I think that's one of the objectives of trying to get together as a group. I don't know if I should start on mine and open mine up and show everybody where we were going. Or does somebody have a dying need to do theirs first? If not, I'm going to jump in.
Go ahead, Mark.
Okay. So hang on a second. Let me share my my document with the group. Because we were going like gangbusters on ours. I was really proud of ourselves. So let me just run up to the top here. So our subgroup, and I'm sorry, I don't want to, I've been the note taker, so I don't want to overstep my role. If anybody else wants to present besides me on this, please don't hesitate. I'll keep the document up here if anybody else wants to summarize what we've been doing. Otherwise, Casey gives me the go-ahead to go for it. All right. I'm going to take Casey's word at it then. So the objective we finally have come up with, it's a bit wordy, but I think we're trying to do a huge thing with this behavioral, cognitive, brain and physical health portion of it. So our objective that we've nailed down is by 2035, and we realize that a lot of the objectives in many of the subgroups do not have measures to provide a baseline for current performance and improved performance. So we put our little asterisk here for that to be filled in the future. But by 2035, older adults and their care partners will have access to comprehensive, trauma-informed, culturally appropriate, effective, and high-quality health and human services and supports addressing a full range of physical, behavioral, cognitive, and emotional needs via a single point of entry to multiple disciplinary, multi-agent system capable of coordinating and meeting diverse preferences for care and social determinants of health. That is a
So are we to comment, or what's the?
yeah. I mean, I think that we're just kind of opening it up for people to kind of have a conversation about. That's where we are, and that's where we landed.
So one point I would make is that if the whole idea is to have collaboration, then instead of multidisciplinary, I would say interdisciplinary.
Thank you. Love it.
I would suggest breaking this up into a couple of sentences and maybe move the health and human services and supports a phrase to the first part so that it would read, and then you would say what all of those supports and services will be, which includes comprehensive, trauma-informed, culturally appropriate, and then the rest of the list. There's a lot of words in here. There's a of wonderful in here. It's just, it's hard to dig through it. So by 2035, older adults and their care partners will have access to health and human services and supports that are, and then everything comes after that.
So my
We'll
one
have
comment is,
access to.
yeah, this frames it as it's access to the healthcare delivery institutions that would then do a diagnosis and then offer a range of modalities of support. So I guess my question is, do we believe that the primary, in reality, family caregivers are some of the key enablers? So I guess my question is, do we want to frame this all around the healthcare delivery institutions, or are there other actors that are important? Social determinants of health, for example, would tell you that the community, the network and support system is as or more important than the healthcare delivery institutions. So I wonder how this fits with what we know about social determinants of health.
I agree with Jim. I think it needs to start with the person, regardless of what dimensions we're thinking about. It needs to start with it. So I think perhaps the diverse preferences would need to move up, because you start with really people preferences for the care that they wanted to see.
So how would you phrase that?
I don't know. I have to think about it.
Well, this is motherhood. I mean, in a perfect world, there would be one-stop shopping, and you would have modalities to everything.
Ask Anne. Anne's raising her hand. And you have.
Yes, I mean, I was just going to say, so brain and physical health is this huge piece of the pie. It's very big, and so many things feed into brain and physical health that we know of, and I think a lot of the other work groups are addressing those things that do feed into brain and physical health. And I think in our work group, there's only so much we can do because we have such a broad charge anyway. It's just hard to boil it down and to sometimes leave to the other groups what we know feeds into brain physical health.
Okay, I'm okay with that.
How are we feeling about the objective? I think it was a great idea, a great thought to break it up. I think that definitely makes it more readable and more sense.
Why are we putting health and human services? Why cannot be older adult and their care partners will have access to comprehensive trauma-informed, culturally appropriate, effective, and high quality care?
I'm sorry, Ray, I didn't catch your.
I think I'm just will have human and health services, and then we're explaining what those are. So why not just? I'm just trying to find a way to shorten it a little bit so it doesn't.
Okay.
It doesn't like it's a mouthful, right? So it's older adult and care partners will have access to comprehensive trauma-informed, culturally appropriate, effective, and high quality care. So you just
Yeah.
So you delete will through,
will have health and human services and support.
and delete have. No, will have access to.
Yeah, I think so. It's just to shorten it a little bit.
Delete health and human services.
All the way to access.
Okay. Will have access to.
Yeah, what do you think? Does that look better?
Mm-hmm.
I think that reads better.
And instead of just physical, behavioral, cognitive, and emotional, we can say this care will address full range of holistic needs, because that's really what it is. The holistic, yeah. So, and you get rid of physical, behavioral, cognitive, and emotional.
May I ask a question here? This is Mary Jo. Are we seeking to limit this to clinical care? The word care implies a clinical component and usually means that this is a medical system. I think the point of probably having the social services in there previously was a means of indicating that, as we know, wellness is not purely a product of care. So it's a question, though, was this intended to narrowly target improved care? And if not, then we need to make sure that we don't inadvertently seem to emphasize that it's a medically based approach.
Agreed.
Supports was in there earlier. Maybe we could go to these supports.
I also think that care is defined further by saying it's a full range of holistic needs. So it's more than just the medical. That's why we broke it out into so many different areas and we just took it away.
But Casey is thinking that we need to expand, not put the word holistic, because people may not know what holistic means. And so I think Casey is saying that. Oh, Casey, you want to go ahead and talk?
Yeah, no, thank you for seeing my comment. I wasn't sure if you would
Yes,
see it.
yes.
I just wanted to make sure it was seen before we got
thank
too
you for
far.
saying that.
Don't worry about it. I'm always on the lookout. I'm always unsure about things.
With me editing, I can't see the screen. So thank you for pointing that out.
No problem. Go ahead, Casey.
Yeah. No, I just wanted to pose the question. While I understand the importance of making something clear to understand with less words, we do want to ensure that it's clear to understand, and that anyone who is coming at this is working from common definitions. And so if holistic health has a common definition in this LRM process that everyone reading it will know what that means, then that's great. If it does not, then I think it's important to have the elements spelled out. So we ensure that they are all appropriately prioritized.
considering this may or will likely be a multi-agency, multidisciplinary, I'm leaning towards what Casey is saying, although it does, I'll leave it up to the group.
I agree with Casey.
Should we say quality of life instead of quality of care? Just like what Mary Jo was saying about care, it puts like a medical tilt on it. But quality of life is what quality of life for each and every patient. It's in the eye of the beholder.
I appreciate you raising that, Rhea, but I think I myself would not support that. I think it's a good thought. But I think we are actually, we are indeed trying to target the care delivery system. It's just that we want to make sure that we do not think that that is the sole channel through which, and I think we're working on it through this enlargement of the language.
Sounds good.
I liked Marlene's suggestion in the chat. She said maybe supports instead of care.
I have a clarifying question. At the end where we say, and meeting diverse preferences for care and social determinants of health, what does a preference for a social determinant of health look like?
I think it was meant for, I think that was meant, that preferences was meant for the care portion of it, and you're right, not the social determinants of health. But I would think that what the diverse preferences for care planning or care plan, I guess, that's what.
How about adding a new verb for care and addressing?
There you go. What do we think? Oops, I heard somebody. Eileen.
Right, at the risk of complicating this further, since we're talking about by 2035, wouldn't it be rational to also speak to the long-range goal of lowering the prevalence of cognitive decline in Maryland and dementia? Somewhere in here. I mean, if we can lower the prevalence, we would be improving public health across the board.
My only concern about that would be that it sounds like a single goal for all of this. And I'm not sure that that particular goal, as important as it is, whether it might be too narrow. I understand it drives so much more, and I agree with you that it might be worth calling out somewhere, but I would not think that that would be the single goal of everything else.
No, and I wasn't suggesting that. I just feels that given Maryland's status as the state with the highest prevalence, that it ought to be reflected in what we're trying to do.
What does the rest of the group think? I could make an argument either way, and I very much understand what Eileen is saying, but I also understand that we also don't want to pigeonhole ourselves to just talking about dementia either.
Well, do we include, I mean, aren't we including dementia when we talk about holistic support that includes cognitive? The cognitive is the cognitive impairment that would include dementia care.
What if to address that kind of that negative paradigm and the negative stereotype about cognitive decline, which isn't every older adult's experience, what if we go back to the fact that this is about brain and physical health, and we say with the goal of enhancing brain and physical health?
I think Anne has her hand. Anne?
Yeah, no, I like that language.
Okay.
And I see that, sorry, Marlene Riley is providing some good comments in the chat as well.
Can she share so I can keep up?
Yeah, sorry. Marlene, are you able to speak?
Yeah, I was just commenting also on not making it specific to the goal of, decreasing decline, because I think the overarching goal is that we're trying to coordinate, make sure that there's a coordination of holistic care that's physical, behavioral, emotional, cognitive. So I think that says that, but you already took it out, so that's fine.
Okay.
I agree with Kim's comment too. Services and supports is the vernacular that we see a lot. So these services and supports.
What do we think?
What do we mean when we say single point of entry?
I think our group was interested in making sure that access to services was easy and holistic and addressed, so you weren't bouncing from one provider to another in terms of services, to really align all of these efforts.
Yeah, I think that's just like our healthcare. If we're talking healthcare, is just so fragmented. I mean, the only place where I see a single point of entry, a place like the VA, it's just a close and coordinated, or Kaiser. But
Well, our maps, our Maryland access points have are trying to be as holistic as possible with their points of service. I'm sorry, I'm trying to keep up with everybody's questions.
yes, go ahead, Marlene.
Oh, sorry, Marlene, you're on mute.
Sorry. I think that since we're trying to make sure that services are coordinated, that single point of entry basically means to make sure that there is increased awareness that if you start with someone because of your one problem, that there's better education for that person to then call in other disciplines. So it's the single point of entry to interdisciplinary multi-agency. It's not a single point of entry like one-stop shopping.
Right.
So
I think that it can work. It's a big goal, but I think it's important.
Yeah, because I see it as like primary care. The primary care is the gatekeeper for other services.
And that's fine. If primary care is that single point of entry, just as long as primary care then make sure that they have access to interdisciplinary, physical, behavioral, etc., and doesn't just stop with one thing and say, okay, that's all we're treating hereby. It's a lofty goal, but I think it's worth keeping.
Yeah. I feel like we've gotten wordy again,
Yeah.
but it's better.
Well, have we, there are 3 more groups that we still have to go through. How
Yes,
are we
ma'am.
doing
Let me-
on time? How are we doing on
Yeah,
time?
we've done, actually, we probably have gone through my 15 minutes here on ours.
Yeah, thank you. I was just about to say that I've been
Let's
kind of
stop
keeping
sharing.
track of time here as well.
I am going to stop presenting mine. Thank you, everyone, obviously, for adding to that. That was very, very helpful.
All
Is
right,
there
so
any-
just to keep us rolling, do y'all mind if we move on to person-centered care, or is there another group that wants to report out?
Here's
All
my
right.
group. Jim, are you there? Do you want to share what you have, what we talked about? Oh, here we go.
So our framework is that we want to optimize the role of the individual for person-centered care around 2 models. One is the individual around the Rao Khan model essentially started with successful aging, where they, in the MacArthur studies, looked at what are the ingredients of people that were highly successful as opposed to those that had disability. So our definitions of person-centered care is 2 things. One is optimizing the individual, or the opposite of ageism, and the second is using the 4M model about how the role of the individual in healthcare delivery is that the 4M model starts with that the first part of that model is matter. What does the individual want? So essentially, we don't have language yet, but essentially the big idea is that our concept of person-centered care is about optimizing the growth and total developmental ability of the individual and we're purposely saying it's not institution based. It's about individual based. So the successful aging model flows into the age-friendly models, which essentially the age-friendly community models says access to volunteering and community activity, access to recreation and sports, access to arts and community. So we're trying to work with existing models. So that's where we are.
I
Raya
just
went away.
reworded our objective a little bit there, Jim, from when we were in our breakout group, just to make it read more about what we were talking about, optimizing empowerment, but also by 2035 also, older adults age 60 and older will be empowered to access services, supports, and programs in order to optimize healthy aging, independence, individual goals, preferences, and preferred living environment. So I don't know if that's anything anybody would like to change or add or take away, but I just tried to make it encompass everything that we had discussed. Looking at focusing on understanding of health versus the medical model, like you said.
Yes, ma'am, go ahead.
I think it's me, Mary Jo, here. Gee, something just popped up and blocked that. It's now blocking that paragraph for me. I think my question was about following Maryland's person-centered planning guidelines. What I'd like to understand, since I don't know those guidelines specifically and toward whom they are directed, does this in any way imply a more, limited scope? In other words, do those guidelines apply only to clinical services? Do they only apply to X type of entity? What I would like to see reflected in here is something that ensures that that this includes the more, community-based services. And I just want to make sure that that phrase doesn't somehow limit it to more formal, either, clinical and or state provided resources.
Yeah, Mary Jo. Jim, go ahead.
I was going to address it. So those guidelines came from the disability part of the Department of Health, and they're focused on the state's commitment that in the disability services realm, that there is an individual plan that the individual and the caregiver and family commit to. So so that needs to be within this big umbrella, but it's a more segment view rather than the big idea, which is everybody should be able to access to services and individual decision making.
And actually, the statement has incorporated some of these guidelines, like the wording from the guidelines, like focus on individual goals and preferences. I think, Jim, we talked about the empowerment, which was really important for people we care for, inclusive and holistic approach, collaboration. So I think it's there. There's one question that I wondered about, it says age 60, but I remember when we had our first meeting with Liz, she was talking about age 50, right? We talked about accelerated aging for some people with chronic illnesses and disabilities. And so we thought that age 50, isn't it true, the Longevity Ready Maryland? Do you remember, Mark, Andrew? I can't remember.
So, frankly, I think they were talking about aging through the lifespan, frankly. So it really depends upon your perspective. I know there are different, as you're mentioning, I think there's different guidelines or federally versus state as to where that line is drawn. And where frankly services and when you can apply for services at certain ages and those kind of things lie, but I think we're looking across the lifespan very often.
Okay.
With Longevity Ready. Yeah.
Should we add the word inclusivity in there as well?
I like that idea, Melissa. Maybe it could be part of the list at the end of the objective.
Yeah, that's what I was thinking. Yeah. Thank you.
And sorry, Janine, I saw that you had your hand raised a little bit earlier.
I did, and it's kind of a broad thought. For consistency across how all the objectives are written, I wonder, should each include the title of the area of focus? Like this, make sure it says person-centered care. For social connection, make sure that objective says social connection somewhere, and et cetera, et cetera. Just something for as we're finalizing all of these.
I think that's a great idea.
Yeah, the format, we will nail down the formatting, but we can put it, you want to put it in the objective? I'm sorry, is that what you're saying?
Yes.
Sure. I don't see why not, but yeah, we will pull back and take a look at all these objectives based on the subgroup, so.
Great. I don't know, did we want to spend a little bit of time looking at the recommended strategies for this group?
The one thing that I had question about is number 6. It then again says age 60 and older. And I'm not sure if that needs to be in there.
This also might be another consistency thing for when you're kind of doing all the finalization across the board, but maybe we kind of stick to calling older people, older adults, like just have a couple of different terms and we don't toggle in too many different ways. And I would suggest using what the Reframing Aging Initiative recommends there, which is older adults and older people.
I actually went back and changed all of the words in the strategies. They originally said patient instead of older adult. So that was
Awesome.
another thing I think we need to stay away from.
Yeah, that just advances negative paradigms, right?
Yes, Mary Jo, I have a tiny copy edit to suggest in number 3. The third line down, where it says including hospital at home, nursing visits and services. Actually, those are 2 separate concepts. So it would be hospital at home, comma, closed paren, nursing visits and services, because the hospital at home is a level above in terms of services that are delivered. And I do thank you for putting that in because I know that I suggested it. So I thank you to the group.
Thank you.
Excellent.
And another small copy edit is technology in number 7 doesn't need to be capitalized. Let's not elevate it any more than it already is in our lives.
Here, here.
And Ben, and sorry to keep copying. I think it's health communication is a better technology. Health information technology is really a term of art that is actually, it gets into personally identifiable health information, stuff like that.
That is well taken, yes. Oh, Marlene, I see you've got your hand raised.
I'm looking for another word. I'm not sure what it is in number 6. I feel like the service providers, I think it should be something higher than just non-discrimination and address competencies. So ensure service providers have, I don't know, help me with some other word, competencies. Because it's not just not discriminating, but it's.
Would we want to put inclusive and equitable?
Yeah, maybe making it more positive than non-discrimination. Put it in a more positive term.
Very nice.
I like that.
Some good feedback there. Casey, I see you've got your hand raised.
Thank you. I have a hunch the group has talked about this at length, but I just wanted to bring it up. The fact that LGBTQ individuals are kind of pulled out as a priority population, I just wanted to ensure that was intentional, because there are certainly lots of identities that can and should be included in person-centered care and planning. So I just wanted to get on it.
Yeah, was there anyone from the group that wanted to kind of comment to Casey's point?
I think when we talked about this a little bit, we also talked about just adding maybe underserved communities.
I was going to suggest something along those lines, like marginalized. I like that, Peggy. Mhm.
Thanks.
Yeah, I know that there's some language around marginalized individuals in other legislation, so I think that might be a good, again, exercising inclusive language. Sorry, Mary Jo, I see that you left a comment in the chat here. For number 7, you can just say embrace technologies that can be used to extend care options beyond the office visit and strengthen individuals and families' ability to manage their own health.
It widens it somewhat, that it's beyond just the clinical, beyond just telehealth and monitoring. I guess there should be a possessive after individuals also.
And you have your hand raised?
Yeah, I was just wondering, I guess it would go maybe in number 2, but stronger language than embrace. I know we really promote the use of mental health advanced directives, as well as just, of course, advanced directives in general. And rather than embrace, I was thinking of language like vigorously promote, or, the use of advanced directives and mental health advanced directives. I don't know if that belongs in there, but it seems to really be an important tool for person-centered care.
Yeah, we have embrace on number 2 and number 7, and maybe
promote.
Number 1 is utilize. Something similar.
I would agree to promote or support.
Or leverage technology.
Yeah, for both 2 and 7. Promote or support.
Those are some good points. Thank you. Peggy, I see you've got your hand raised.
Yeah, thank you. So just going back to number 3, we did talk about it in our group a little bit. Is that where we're talking about including things like hospital at home, nursing visit services. I think we might also want to put something in there like community-based palliative care as well as hospice.
I would advocate for including behavioral health in that list as well.
Agreed.
Yeah, those are some good points.
And community-based palliative care, which is different from hospice.
Okay.
It would be. And then the next word is hospice. Sorry. There you go.
Perfect. All right. Well, that's some great feedback there. But again, as Mark has mentioned, if we wouldn't mind keeping an eye on time and moving over to the next working group. Do we have a preference on whether we'd like to discuss social connections or transportation infrastructure?
My vote is for social connection.
All right.
I can pull up my screen.
All right. I'll let you present
You have
them.
it. Never mind. If you've got
Okay.
it. Here, I'll go away.
Okay. And I apologize if my voice is a little hoarse today. I'm recovering from an illness, but the main objective that we have as it reads so far is work across nonprofit government, non-governmental agencies, and individuals at the state and local level to develop effective strategies for improved social infrastructure and develop state guidelines for social connection that align with the National Strategy for Social Connections. Okay. Thank you, Marlene. Including that consistent language by 2035.
And I think we just need a comma between the word nonprofit and government.
Thank you for that.
We were kind of, as were the other groups, in the middle of a good discussion when our time ran out. But one thought I had around this objective is how it states to develop effective strategies for improved social infrastructure with all of these entities that are stated, that are aforementioned. And that's what we're doing right now. So I kind of feel like the development of the strategies should be changed to the implementation of the strategies.
And it should lead, don't you think? It should, by 2025, that you would have implemented the strategies that were developed by.
Exactly. Yep.
Yeah, that's a good point. All right, so it sounds like we've got some consensus on the objective then.
Again, I think we're going to take out the will work across government. That's going to go at the end. It's going to read by 2035, implement effective strategies. And because your goal is to get to the strategies, not to the work.
Okay. So we're looking at taking this section and moving that towards the end?
Somehow, it's going to take a little more editing than that, which maybe we don't have time to do in real time. But and I have a question that I should have asked perhaps in the breakout. We actually don't have much detail in our objective, like has been added to some of the other objectives. And one question I would have is, how important is the National Strategy for Social Connections? Is that a catch-all for everything that we want to do? I'm not familiar with it. I should have been. But our two previous objectives state a little more explicitly what we're trying to accomplish. And I'm not sure, and we unfortunately didn't really dive right into that. We emphasized the combined and cooperative development of the strategies.
So, Mary Jo, I think in the last meeting, we kind of, I think we were steering, and anyone is free to correct me if this is not how you understood it, but we were kind of steering away from being so specific in the objective, because in the strategies and the recommended strategies, that's where we wanted to really get the nitty gritty. So we wanted the objective statement to kind of be a broad statement of what is included below, and keep the language as simple as possible in that respect. That was we decided we were going to work backwards. So when we met last, we worked on those strategies first, and then never actually got back to the objective statement because we ran out of time. So I'm not a fan of a lot of words in the objective statement. I think certain things get lost, but again, I'm flexible in that respect as long as it is reflective of our recommended strategies.
I guess I would love to have some words in there, though, that get to the notion of what social connection means. Social connections. By definition, social connections are intimate, right? And somehow this statement has a very high level feel to it, that everything is going to happen only at a high level. And I wish I could edit in real time a little bit better.
As a yes and to you, Mary Jo, I think we also could use in here the reason why, as you're saying, the reason why social connections are important is because it improves our physical, cognitive, and emotional health. It improves community health. And so I think maybe having that purpose in here would be helpful. It's I don't know if it's as detailed as you were talking about, but I think it needs to be said, because otherwise this sounds fluffy. And I don't agree to say social connections 3 times in here, but that can be taken out in the.
Well, it's certainly not social connections we'll implement. So maybe if we move on, maybe some of us could do some editing in the background and go on to transportation and come back with a suggestion.
I would like to also add that I think every objective should focus on the target population. And that's not in here at all about the aging population being the whole reason that we're doing this.
That's a great point. Maybe we can pull language that we have from the recommended strategies where we talk about why it's important to have, we're all growing older. And this is about, I don't want us to also focus so much on us versus them, a segment of the population being older adults. We're all getting older. So where are my notes here? We had talked about using positive paradigms in aging as well. So let me pull my notes here so I can be more specific about this feedback. But we're all aging and our communities are better when they include the full scope of our energy, ages, contributions, and imaginings. So I'm all for identifying older adults and maybe even caregivers in here, but how can we make it about us? How can we be inclusive rather than, talking about older adults and caregivers as if there's somebody other than all of us?
Mm-hmm.
Well, again, I'm wondering if we should maybe go on to transportation while some of us maybe wordsmith a little bit behind the scenes, including everyone. I like the comments that have just been made. I'm not sure I've yet grasped it yet, but I'm confessing that I'm not seeing us get there right now.
Yeah,
To-
that's
that's where I think we could be specific, though. I don't want to lead this when
Oh, okay,
on
okay.
on the cusp of something here, but this is where I think we may be putting in to, to enhance or improve physical, cognitive, and emotional health as we grow older, And then I think we're at least alluding to the population. We're not saying older adults specifically, but we're talking about aging. And we're talking about a goal to improve health through social connections, health and wellness.
The other option, Andrew, is in that very first sentence, by 2035, the Maryland Department of Aging will implement effective strategies for our aging population. Or is that not a positive feel? I mean, we are all aging, no matter how old we are.
I hear you on that one, Melissa. I think the thing about that is when we talk about our aging population, it's all of us. It's not like we possess the population. So, they're not ours. They're humans and they're all of us. So how could we say effective strategies as we age, as we grow older, or yeah. For all of us as we age, the strategies to benefit all of us as we age. Well, this is getting closer. Thanks for listening to all my comments, and these are great comments from other folks too. Thanks for the perspective.
sorry, I'm seeing that note in the chat from Marlene Riley.
Yeah, I don't mean to go back. I just wanted to have it since it's being recorded. I just wanted to put it out there for later.
Okay. The reference to the Maryland plan seems to be specific to intellectual and developmental disabilities. Maryland's person-centered care planning guidelines are designed to help people with intellectual or developmental disabilities create a plan to achieve their goals and live independently in their community. Is there a broader PC plan that I don't see online? Okay.
Yeah, I don't want to get off track because we already talked about it, but I think it will need to be addressed if it's going to move forward because it's not a broad plan, that's all. But we can move forward with social connections.
Okay.
I see the resource that was shared, National Strategies for Social Connectiveness. Mary Jo had mentioned she hadn't seen that before, and I hadn't either. And as I look at the opener, I think we are addressing, and with a positive paradigm, what the framework suggests, which is about addressing social isolation, loneliness, and social disconnection. But again, we're doing it using a positive paradigm and not catastrophic language.
Thank you. All right. Was there any more tailoring that we wanted to do on the objective, or do we want to start looking at some of the strategies here in the time we got left? All right, I'll go ahead and scroll us down here just a little bit.
In number 2, do we want to be more inclusive beyond just state agencies? Because in our objective, we talk about other groups. So we might want that included here.
Yeah, that's a good point. Yeah, does anyone else have any kind of comments or edits to that wording there? I might actually push back against that one a little bit. It seems like some of the other strategies here target those healthcare providers and other institutions. So I think this one might be calling out those state agencies in particular.
That makes sense. Thanks for clarifying.
Just to comment on number 1, if I was coming in as a layman, I would not understand designing the built environment. Not sure what that means.
We do have in our notes below specifics about what we mean by that. So those maybe could be cut and pasted there.
Oh, very good.
Yeah.
Yeah.
Yes. Perfect.
Oop. Don't know why that didn't want to work. Okay, there we go. We had mentioned earlier trying to find some of those areas that kind of cut across the different subgroups that we've got here. And I think that there are some definite areas where we've got some cut across points here, especially for advocate for diversity, equity, and inclusion across settings. Going back to the point that we were making in the person-centered care objectives and strategies regarding accessible materials for LGBTQ+ and other minority marginalized populations. So I'm just going to be flagging that for our reference here.
Are you suggesting it's redundant and we should remove it?
No, I don't know if I'm suggesting that it's redundant, but I think that might be something to look at from a larger Longevity Ready Maryland perspective. Casey, I see you've got your hand raised.
Thank you. The phrase intergenerational comes up only a couple times. I think I'm only seeing it in number 7 perhaps. And so I'm thinking for number 6, it could be a nice layer to add intergenerational diversity, equity, and inclusion to really get at the heart of this objective.
Yeah, I think that's a very good point. Okay. And again, just keeping an eye on time, I realized that my timer just went off here and you guys could hear that. So that's signaling that we've reached the 15 minutes here for that we've got allocated for this topic. Although I see Eileen had a comment that she'd made.
Yeah, I was just saying I didn't see any references to senior centers, which have really become in so many communities such a hub of activity for people, or even lifelong learning as opportunities for social connection, and was just asking if that should be incorporated in some way.
I think we assumed that it was the community centers was inclusive of that, but we could be more specific.
Okay.
Yeah, Joe, I would,
Yeah,
I
so
would
that's
quickly like to put somewhere something that's only exists under the built environment, one of the subheads, which is, as you know, my interest in the village model and the neighborhood level for social connection, because after all, that is where social connection happens. It happens in the neighborhood. It doesn't happen in many of these other contexts. And so one way to do it might be under number 2, put a comma at the end and say something like including those that that support neighborhood level programs. That's just a suggestion for one location for it.
Yeah.
I know that we've been, cutting people, off at certain times to move on to the next one. But, we do have these links, and you certainly could add your comments to these links as we leave here today. So
Good.
please feel free to continue to make suggestions and make comments as we move forward.
Thank you.
Yes, ma'am.
All right. And I think that is a good jumping off point to move on to our next section here, which is the transportation infrastructure goals and objectives.
Brenda, you
Sorry,
can comment?
yeah.
Brenda, you might be you muted, I think.
You are exactly right. Thank you, Mark. Chatting away. I do apologize for that late raised hand. I was wondering by community centers, are senior community fitness centers included? Robin Riley chimed in and said, yes, I would add senior centers language as they provide social connections, nutrition, and access to health connections. So we just wanted to raise that point.
Yeah, that's an excellent point.
Yes, yeah, and again, if you could pop it into the document itself and just put it in as a comment, if we didn't capture it already, don't hesitate.
Thank you very much.
And I see Casey, you've got your hand raised as well.
Yeah, I just wanted to check in and see if other folks on the call are able to leave comments on these documents, because I don't seem to be able to.
Uh-oh.
Is anybody else having challenges accessing the documents and editing? Or at least putting comments? You should at least be able to put comments.
It looks like Janine is having trouble as well.
One thing I'm noticing too is that I'm seeing a couple of folks show up as anonymous contributors. Perhaps if you sign in with a Gmail account or another account with your institution, that might be able to, yes, make sure you're in the shared drive and not the attached documents. Thank you, Marlene. Yeah, so that's a good point there that she'd mentioned. If you are trying to make comments, please make sure that you are in the shared drive and not the attached documents that were included in that last email. At the bottom of that email, we've got the links listed so that you can click on those links, and that should bring you to the document in the shared drive. All right. And it looks like Janine can comment now. Thank you.
Excellent.
All right. So for the folks in transportation infrastructure, the objective that we came up with following that recommendation from the Department of Transportation conversation is it currently reads, by 2035, increase investment in transportation services that promote accessibility, age-friendly design, and walkability through funding, technical assistance to local communities, and the coordination of state resources and programs. Any initial thoughts on that objective as it reads?
I love it. I think it's really concise. It's specific. Nice job.
All right. Thank you, Jennifer.
I also like the age-friendly design piece in there too, because I think it speaks to what we were saying earlier about aging versus older adult versus 65 and older. I think it's a great way to put it.
Great. Yeah, see, Brenda, I see you've got your hand raised.
Yes, and my mic is on, so there you go. Just wondering, should we put a note in there about safety some way that promotes? I don't know. Anyone have any thoughts on that, or it's implied, so we don't need to state that specifically, because that could be an extra investment.
So in age-friendly design, when you're talking about mobility, usually the terms walkability, accessibility, age-friendly design, they do imply that people can safely get from A to B. And that is a given. But again, depending on who's reading this document, it may need to be specifically spelled out.
Yeah, I don't want to. Oh, yeah, and I see Carrie mentioned that is somewhat covered in the first strategy. Yeah. Carrie, did you want to weigh in on this?
I mean, just to kind of reiterate what I just typed in the chat, I think it gets to that a bit. If we need to hone that more, we certainly could.
Yeah.
Yeah, this is Bruce. I mean, I wouldn't be opposed to adding. I mean, safe is. I mean, safe for people. Any transit system should be safe, just given the scale and potential challenges with it. So yeah, I don't think that hurts to promote a safe. That promotes safety, accessibility, and age-friendly design. Yeah, I mean, it should be safe. It should be accessible, and should be available to anyone, kind of depending on their circumstances.
Yeah. So it seems like there's a bit of consensus on that objective. So do we want to kind of jump a little bit more into the strategies? Or I see that Mark is unmuted here.
Just real quick, just to wordsmith, I think it needs to be promotes instead of promote.
Yes.
Thank you, sir.
Mary Jo?
Number 8, I think we could expand it a little bit very simply. Hold on, I have to lower my hand so I can see what I'm saying. So I would add, after self-driving cars, I would add, and community-based services. Because, there are a lot of now free community-based services operated by a diverse array of entities, like rideshare, but also, Call a Ride, and villages certainly, provide a lot of transportation. So, yeah, you would not, it's not technology. So the closed paren would come after 7 self-driving cars. So the closed paren would come after cars. And then delete the parenthesis after. And community-based services, add as a separate phrase. Yeah, there you go. And there you go.
Perfect. Thank you. Yeah, I think noting our earlier conversation about highlighting any areas that might be, if not overlapped, addressed in multiple areas, I think we might be able to talk a little bit more about the connection between the built environment, as we discussed in the social connections objective, and the community transportation services and land planning that we talk about here. So I'm just going to highlight that for my reference.
Thank you for doing that, Andrew. I think,
Yeah, of
you know,
course.
this is just one example of many. I think that we'll see that the strategies may, you know, straddle more than one of the subgroups. And we'll have to internally review them and go over it.
And I don't want to kind of hop in here and editorialize, but it seems like we've reached a little bit of consensus here. So I want to make sure that we've got time for final comments and suggestions and wrap-ups from the group. So Raya or Mark, is there anything you wanted to discuss before we end this meeting?
I don't think so. I think that's really a great discussion, and I think this is as tight as we can have it.
Sorry, I see Marlene's got a comment.
This is another one of those sort of cross-cutting comments that I feel like that we need to make sure that there's capacity building. Because just for example, like Mark had mentioned, Maryland Access Point, and that's a really good service. But if we do improve communication and we do make everyone know about it,
Exactly.
so like I want all those things to happen, but not to then have all of the current staff really, you know, just
Right.
quit all the time.
That's a very
So-
good point.
So capacity building needs to be part of this.
And again, I think that's, you're right on the money. I think that's going to be a cross-cutting, you know, on a lot of this is going to be about where are the resources to make this happen, right? But yes, excellent point. Yeah, I you know, from my perspective, again, I don't see this as an end. I see this as a beginning, and a great beginning for where we are. Considering, I want everybody to take a moment and just think about where we started and where we are. I think it's very, very impressive what we've been able to achieve, and just the brain power and the coordination of this group to get where we are has been tremendous. So I personally want to thank you for taking the time and bringing your expertise and your skill set to the table to help us with this. Again, this is these documents are still going to be open. Please add your comments along the way. I don't want you to think that this is, I know this has been a whirlwind of an effort, but we're very you know, we're still in the process of making these as good as we can make them. So don't feel like you're done or that we don't want to hear from you. We certainly do want to hear from you, but we do need to draw lines here and there to just make sure we're moving forward.
Thank you for making it such an engaging process.
Well, that's all, Raya. And Andrew. I'm not that engaging.
Oh.
It's been wonderful. And I just put down, you know, thank you everyone. It's been really difficult just to make time, but it's just so wonderful to get to know everyone and really hear different perspectives, because that's what it is, especially for us, for instance, clinician, we're just so, you know, narrow sometimes. And, you know, so I think it's just so important. I think this is how we get things done, when we hear different perspectives and work with multi-sectors and understand how holistic care does not mean institutions and healthcare. So it's just wonderful. Thank you very much. Very cool.
And if you do see us change or edit and it's not what you had envisioned or were trying to explain, please help us try to get your thoughts down in the way that is expressed in the document, because we don't want to misrepresent what you're trying to relay to us. And certainly stay engaged with, we're going to have town halls, we're going to have things online, we're going to have opportunities to continue to engage beyond this. So please stay engaged with all of the different avenues we'll have to continue to provide feedback. Any
Thanks,
last?
everyone.
All right. Well, thank you again and have a great rest of your day. Thank you so much for all your hard work.
Take care, everyone.
Take care.
Thanks.
Bye-bye.